Have you ever really stopped to think about how your eyes react to light? That instant shrinking or widening. It's pretty amazing.
It really is. Just happens automatically.
But what if, say, you looked in the mirror or maybe noticed it in your pet and one pupil was, well, different, bigger or smaller than the other?
Oh, yeah. That's actually a thing.
Right. Called Anisocoria. And that's the intriguing puzzle we're going to unpack today.
Definitely a puzzle. And hopefully this deep dive will help you piece it together. If you've seen this, you've probably wondered, okay, what's going on here? What are the eyes trying to tell me?
Exactly. We're going to get into what happens when those pupils, which normally match, decide to, go their own way size-wise.
And we're using a source that gives a really thorough overview of Anisocoria, specifically how it shows up and gets diagnosed in dogs and cats.
Now, I know what you're thinking, dogs and cats. But stick with us, because the basic idea is here. They apply much more broadly. It's super useful for understanding the phenomenon itself.
Absolutely. The goal here is to really boil down the key information, explain the why behind Anisocoria, and show you why this simple visual cue can actually be, well, pretty significant.
Okay, so the basics first. What is Anisocoria?
Simplest terms. It just means the pupils aren't the same size. One's bigger or one's smaller than the other, noticeably so.
How about it? Unequal pupils.
Precisely. And the interesting thing is that difference usually signals some kind of disruption, right? On one side of a system that's normally in balance, like a seesaw tipping.
A seesaw. I like that analogy.
Yeah, and for pupils, that tilt usually involves one of two parts of the nervous system controlling pupil size. First, there's the sympathetic nervous system.
Okay.
In the eye, its job is basically to make the pupil get smaller to constrict. We call that meiosis.
Right, like stepping into bright sun. Both pupils should shrink down meiosis. Protects the back of the eye.
Exactly. Then, the other side of the seesaw is the parasympathetic nervous system. Its job is the opposite. It makes the pupil dilate, get bigger. That's mydriasis.
Like walking into a dark room. Pupils open up wide to let more light in. Mydriasis.
Perfect. Now, it's also really important to remember, it's not always the nerves. Sometimes diseases directly affecting the eye itself, we just call that ocular disease, generally can cause anisocoria too.
Okay, so it's either a problem with the nerve signals telling the pupil what to do, or it's a mechanical issue within the eyeball itself.
That sums it up nicely. And you might be surprised, it's actually pretty common.
Really?
Yeah, the source mentions it's seen frequently in dogs and cats, all ages. Doesn't seem to matter if they're male or female.
Okay, so not some super rare medical mystery then. Good to know. So let's dig into those signaling problems first, the neurological causes. Our source breaks this down well. Unequal pupils can definitely be a heads up about something neurological.
And the absolute first, most critical question is, which pupil is the abnormal one?
Right.
Is it the big one that should be smaller, so mydriatic, or is it the small one that should be bigger, myotic? Figuring that out tells you where to even start looking.
Makes sense. So let's take the first scenario. One pupil is big, dilated, and it doesn't shrink down like it should when you shine a light on it. The source calls this mydriasis inability to constrict. What could cause that?
Okay, this is where it gets interesting. If you see that big pupil and light directly in that eye doesn't make it constrict, but shining light in either eye makes the other normal pupil constrict.
Ah, the indirect reflex is still working.
Exactly. That pattern often points to a problem along the optic nerve pathway on the same side as the big pupil. Or maybe at the optic chiasm, that's like a crucial junction where some nerve fibers cross over in the brain.
So the seeing nerve pathway.
Right. Things like inflammation of that nerve, neuritis, or even a tumor pressing on it could be the culprit. And this is where vets might use, an MRI to get detailed pictures, or maybe a CSF tap to check the spinal fluid, or even an ERG test to see how the retina is functioning.
Okay, so an issue with the signal getting in from that eye. What's the other possibility for a pupil stuck wide open?
The other main possibility is a problem with the signal going out to the muscle that actually squeezes the pupil shut. This involves a different nerve, the oculomotor nerve.
Okay.
If that nerve, or where it starts in the brainstem, is damaged maybe by encephalitis, which is brain inflammation, or a tumor or trauma, maybe even a mass growing behind the eye, you'd also see a dilated pupil that doesn't react well to light.
And the diagnostic tools are similar. MRI, CSF tap.
Yeah, MRI and CSF taps are common. And if they suspect something behind the eye, an ultrasound of the orbit, the eye socket area, can be really helpful too.
Okay, that makes sense. Big, unreactive pupil could be an incoming signal problem, optic nerve, or an outgoing signal problem, oculomotor nerve. Now, flip side, what if one pupil is tiny constricted, and won't open up properly in the dark. Meiosis, inability to dilate.
Right. This scenario often suggests a problem with that other system, the sympathetic pathway. Remember, sympathetic usually dilates the pupil, part of that fight or flight response.
Okay, so something's blocking the open up signal. Where could the blockage be?
Well, the source lists a few key spots. It could be high up in the brainstem itself. Again, things like inflammation, a tumor, or trauma there could disrupt the signal. Diagnostics, probably MRI, maybe a CSF tap.
So trouble in the main control center. Where else?
The sympathetic nerves travel down the spinal cord for a bit, then come out in the upper chest area. So problems in the spinal cord and the neck or upper back, specifically the C1 to T2 region, or involving the brachial plexus nerves around C6-T2.
The brachial plexus, that's the bundle of nerves for the front leg, right?
Exactly. So trauma there, inflammation of the cord, myelitis, a tumor, even sometimes a slipped disc, though that's less common for this specific sign, all can interrupt the sympathetic pathway to the eye.
Wow, so a neck or back issue could show up as just one small pupil. That's not obvious.
It's definitely not. The pathway is long and winding.
Yeah.
Another spot is the vagosympathetic trunk, a bundle of nerves running up the neck alongside the jugular vein. Trauma to the neck, maybe even accidentally during a blood draw from the jugular, could potentially damage it. An MRI or ultrasound of the neck might help find issues there.
Goodness, the list keeps going. The source also flags the middle ear, the tympanic bulla, and the trigeminal nerves.
Yep. The tympanic bulla is that bony bubble housing the middle ear structures. An infection in their otitis media, or a tumor or trauma, can affect the sympathetic nerves passing nearby. CT scans are usually great for looking at that bony area.
And the trigeminal nerve.
That's another cranial nerve. Issues with it, like inflammation or a tumor, can sometimes, maybe less commonly, also lead to meiosis, that small pupil. MRI would be a likely tool to investigate that nerve.
Okay, phew. That's a lot of neurological possibilities. Let's switch gears to problems inside the eye itself. The source has another table on ocular diseases causing anisocoria.
Right. These are conditions directly messing with the eye's structures. Like anterior uveitis, that's inflammation in the front chamber of the eye. That often causes a small pupil, meiosis. But you'd usually see other signs too, like maybe the eye looks cloudy inside, the cornea might be swollen, the white part looks red and angry.
So, other obvious signs of an unhappy eye. What causes uveitis?
It can be triggered by infections, systemic inflammation, injuries, even tumors inside the eye. Lots of possibilities.
Gotcha. What about an eye problem causing a large pupil?
Glaucoma is a big one. That's when the pressure inside the eye gets too high.
Right.
Glaucoma often leads to a dilated pupil, mydriasis, that reacts poorly or not at all to light. You might also see that corneal swelling, and of course measuring the eye pressure would be key. Glaucoma can just happen, or it can be secondary to something else going on in the eye.
And tumors in the eye, can they cause either?
Absolutely. Depending on where a tumor like lymphoma or melanoma is growing inside the eye, it could push things around and cause either meiosis or mydriasis. Sometimes you might even see the iris color change.
Interesting. The source also mentions posterior synechia and iris atrophy. What are those about?
Posterior synechia sounds complicated, but it just means the iris, the colored part, gets stuck to the lens behind it.
Ah, okay.
It often happens after that anterior uveitis we talked about. It can make the pupil look irregularly shaped and not react well to light.
And iris atrophy.
That's more of an age-related thing. The iris tissue just gets thin and weak over time. It can lead to a weird pupil shape too, maybe sluggish reactions to light. Just part of getting older sometimes.
And there are congenital things, like iris hypoplasia, born with it.
Yeah, hypoplasia means underdeveloped. So the iris didn't form completely right from birth. That can cause poor pupil light reflexes, an irregular edge to the pupil, and you often see other eye abnormalities along with it.
Okay, so neurological issues, direct eye diseases. What else? The source mentioned pharmacologic blockade, like drugs.
Exactly. Sometimes eye drops can cause it. The classic example is atropine. It's used sometimes to dilate the pupil for exams or treatment, and it can cause a big dilated pupil that won't constrict even though vision is fine. It just blocks the signal chemically.
Huh. And what about spastic pupil syndrome?
That one's a bit odd, seen more in cats, and it's been linked to the feline leukemia virus, FLLV. It typically shows up as a small pupil, meiosis, but the cat can usually still see okay.
Wow, okay. That is a huge range of potential causes, from brain tumors to eye drops. It really hammers home that just seeing the unequal pupils is only the very beginning.
Couldn't agree more.
So how do you actually start sorting this out? The source really stresses figuring out which pupil is the abnormal one first.
That is absolutely step one, job one. Is the problem the small one that won't get bigger or the big one that won't get smaller? That single determination is huge because it immediately points you towards suspecting either a sympathetic system issue or a parasympathetic one. Narrows things down dramatically.
And then diagnostics. We mentioned imaging.
Right. Imaging is crucial. Ultrasound is great for looking at the eye, behind it, maybe even the neck area. MRI is the champion for brain and spinal cord details. And CT scans are often best for bony stuff, like that middle ear bulla.
And you also mentioned CSF taps and ERGs.
Yes. A CSF tap lets you analyze the fluid around the brain and spinal cord, looking for inflammation, infection signs. An ERG tests the retina's electrical function, really useful if you suspect the optic nerve or retina itself might be the source of the problem.
Okay. Now, there's a figure in the source, figure 1. It looks really useful. It talks about using different eye drops of pharmacologic testing to help pinpoint things further. Can you walk us through that logic?
Yeah, it's pretty clever, actually. The idea is to use specific drugs and see how the abnormal pupil reacts. The reaction, or lack thereof, can help figure out if it's a sympathetic or parasympathetic problem, and sometimes even give clues about where along the nerve pathway the problem might be, like before or after a nerve relay station, what we call preganglionic versus postganglionic.
Like testing different parts of an electrical circuit.
Kind of, yeah. So let's take the first case in the figure. You've got a small pupil in dim light, but it does still constrict normally when you shine a bright light in the eye. That suggests the sympathetic system isn't working right, it's failing to dilate. Here, they might try hydroxyamphetamine drops. This drug basically nudges the nerve endings to release their signaling chemical, norepinephrine. If the small pupil dilates after the drops, it means the nerve fibers after the relay station, the postganglionic ones, are okay.
So the problem's further back.
Likely, yes. Maybe preganglionic or even central brainstem, spinal cord, neck nerves. But if the pupil doesn't dilate with hydroxyamphetamine, that suggests the problem is right there in those postganglionic fibers, maybe closer to the eye, like an issue related to the middle ear or trigeminal nerve.
That is clever.
Yeah.
What about the phenylephrine test mentioned there, too?
Phenylephrine works differently. It directly stimulates the sympathetic receptors on the iris muscle. We usually use a 1% solution. If the small pupil dilates with phenylephrine, it confirms the receptors themselves are working. If it doesn't dilate, it could suggest those postganglionic nerve endings are basically offline denervated. And again, that points you back to investigating those same areas. Central nervous system, brachial plexus, neck, middle ear, trigeminal.
Okay, that covers the small pupil investigation. What if the pupils are big, dilated, maybe roughly equal in the dark, but they don't constrict properly with light? The figure says this suggests parasympathetic dysfunction, and that's where physostigmine comes in.
Correct. Physostigmine stops the breakdown of acetylcholine, the parasympathetic signal chemical. If you put in a 0.5% drop and the pupil constricts but slowly, that's pretty normal.
Okay.
But if it doesn't constrict at all, that suggests a postganglionic problem. Either the iris muscle itself isn't working, or the oculomotor nerve controlling it is damaged right near the eye. Now, interestingly, if it constricts really fast, that can actually point towards a preganglionic lesion further back towards the brainstem or along the oculomotor nerve pathway.
Oh, okay. And pilocarpine, how does that fit in?
Pilocarpine is like phenylephrine, but for the parasympathetic side, it directly stimulates the receptors on the iris that cause constriction. We use a really dilute version, like 0.2%.
Why so dilute?
Because a normal eye usually won't react much to such a weak solution. But if there's a nerve problem making the receptors hypersensitive, even that tiny amount might cause rapid constriction. That suggests the iris can constrict, pointing the finger at a lesion affecting the iris, the oculomotor nerve, or the brainstem. If there's no constriction at all, though, it might mean the iris muscle itself is damaged, like an iris atrophy, or sometimes it's just a normal finding not to constrict to that weak dose.
So these drops are like little diagnostic keys, trying different locks in the nervous system pathways. But the source adds a note of caution, right? That using only these tests to distinguish pre- versus postganglionic problems can be tricky.
That's a super important point. These tests are really useful clues, absolutely. But they aren't foolproof in isolation. You always have to look at the whole picture, the history, the other exam findings, the imaging results to really nail down the diagnosis. The drops help guide the investigation, but rarely give the final answer all by themselves.
Right, context is everything. Okay, so finally, what about fixing it? Treatment and prognosis.
Well, as you've probably guessed from the sheer variety of causes we've talked about, the
Yeah.
treatment is all about finding and addressing whatever that underlying cause is. Fix the ear infection, manage the glaucoma, address the neurological issue if possible. There's no single anisocoria treatment.
Hmm.
And the prognosis, the likely outcome. Same deal. It completely depends on the diagnosis. Treating uveitis from trauma is very different from managing a brain tumor, obviously.
Makes total sense. Okay, so let's try and wrap this up. The big takeaway seems to be that anisocoria, just seeing pupils of different sizes, it looks simple, but wow, it can stem from a huge range of things. Neurological issues way back in the brain or spinal cord, nerve problems in the neck, or problems right there in the eye itself.
Exactly. And the absolute key, the starting point for unraveling it, is that first observation. Which pupil is the abnormal one? Is it too big or too small for the current light conditions?
And from there, it's about a logical investigation using exams, maybe imaging, sometimes those clever pharmacologic tests, to track down the root cause.
Precisely. A systematic approach is crucial.
So for you listening, it's kind of a fascinating reminder, isn't it? How these seemingly small, subtle physical signs can actually be windows into much bigger, complex systems working or not working inside the body. Makes you wonder what other little details might be telling a story.
It really does, and maybe it prompts a question for you to think about. How tuned in are we, really, to these subtle bodily signals in ourselves or others? Anisocoria is just such a clear example of how interconnected everything is, how a problem way over here can show up way over there.
Absolutely. So if you ever do encounter this in yourself, a family member, a pet, remember this complexity we've explored. It's usually a sign that warrants paying attention, maybe doing a bit more digging with reliable sources or, checking in with a healthcare professional. It really speaks to the amazing, intricate design of the body.